Thank you, Claire. It's a pleasure to be here. Thanks very much. I am going to try and do a whistle-stop tour of, well, actually Perils in Epileptology. I'm not so sure I'll do Perils in Neurology in a half an hour. I'm not so sure I'm going to do Perils in Epileptology in a half an hour. So, and it's clinical perils and how to avoid some common perils. So, when we're talking about something, let's start with a definition. The simplistic definition of epilepsy is an individual who experiences recurrent unprovoked seizures. This is a more comprehensive definition of epilepsy, so it defines a group of brain disorders. We now really think about the epilepsies rather than epilepsy, affecting individuals of all ages, of varying and often unknown etiology. This is quite frustrating. At least half of the time we do not understand why somebody has developed epilepsy. Characterized by recurrent unprovoked seizures, or now by one unprovoked seizure but with an enduring predisposition, quote-unquote, to further seizures. By this we mean somebody has a first unprovoked seizure and either generally on electroencephalography or on imaging we find abnormalities that would put this individual at significant risk for further seizures. So we now conceptualize this person as having epilepsy and possibly initiating treatment after the first unprovoked seizure in that setting. The epilepsies may have significant consequences in terms of adverse educational, vocational, and psychosocial functioning, issues with regard to physical morbidity. I frequently am shown photographs on the smartphones from patients after they've had a seizure with horrendous lacerations, facial lacerations. We know the patients are at risk from burns. Some of our patients, unfortunately, end up in burns unit. I have one patient who picked up a kettle in a complex partial seizure, a kettle of boiling water, and poured the boiling water on her chest. We're not talking about convulsions here. I'm talking about what some people would mistakenly describe as minor seizures. And of course, also individuals with epilepsy have a statistically overall a twofold increase in standardized mortality. This would include accidents, drowning, and in about half the time a phenomenon called sudden unexpected death in epilepsy, SUDEP, which usually occurs in individuals with refractory epilepsy. So these latter problems, and also there's issues, of course, with regard to driving, which is a huge issue, which I'll touch upon a little bit later. These issues really occur in about 1/3 of individuals who have refractory or pharmacoresistant epilepsy. So epilepsy is not just seizures. There's a lot of comorbidity attached, particularly to drug-resistant epilepsy. Harry Lee Parker apparently was an outstanding teacher. He was one of the first neurologists in Ireland. He spent some time here in the 1950s. He came from the States, he went back to the States. I'm not so sure why he left Ireland, but you can maybe guess yourself. Was it the weather or was it the healthcare system in those days? I'm not sure. But this is a quote from his textbook, which you can buy for about 400 or 500 euros on Amazon if you're lucky enough to get a copy. So he was a fantastic teacher and would do clinical rounds with his students. And this quote is worth reading through because it's essentially still true today. And so today you have seen two extremes of epilepsy. In the first case, the disease is one I call a malignant type. It has worsened steadily and remorselessly since the first minor attack and will continue to get worse. Despite all our more modern remedies, medication has failed and the patient is a total loss to society and a misery to himself. The second patient has what would certainly call a benign type of epilepsy, easily controlled, and for all I know, she might have recovered without any treatment. There is no rule in epilepsy that cannot be broken, which is my favorite quote with regard to epilepsy. It is, sorry. Can I go back a slide? It's not, can we go back a slide? Anyway, you get the point. The point is that there is a wide variation in people with epilepsy, and we're really struggling with the same problems today, despite all our new treatments and over 20 anti-epileptic drugs being available. I'm not going to lecture you on how to take a history, obviously, and how to make a diagnosis, but just to belabor the point that it is frequent that we are asked to see patients in the hospital, for example, with collapse query cause. Now, the differential there is usually between an epileptic seizure, which occurs without warning, or some sort of syncopal attack. But it is amazing to go and see these patients who've been in hospital for 7 or 10 days. They've had a multi-$1,000 workup, but nobody's actually taken the bother to pick up the phone and get a collateral history where it is available. So a collateral history of these attacks is extremely important. This is basic, it's not rocket science, it's common sense, but it's amazing how uncommon common sense is sometimes. Inquire about risk factors. These would include early childhood risk factors, what we call early precipitating injuries. This would be complex febrile convulsions in childhood, history of encephalitis, history of meningitis, history of significant head trauma associated with loss of consciousness, or anterograde or retrograde amnesia. Examination is usually normal, of course not always normal. We need to interpret investigations with caution, and I will discuss this. And we would like to, this is not again a lecture on epilepsy classification or seizure classification, but certainly as neurologists and epileptologists, we like to make a specific syndromic diagnosis. There is no such thing as grand mal epilepsy. There's only a variety of epilepsy syndromes, of which a tonic-clonic convulsion is a part of that person's epilepsy. And the other thing is a bugbear of mine, particularly on consults. You will see the medical SHO, and I was there once, so that's okay, who will again be admitting a patient with collapsed query cause, and the differential diagnosis is query syncope, query seizure, query TIA. TIAs do not cause loss of consciousness, so let's just get that out of our hospital charts, please. And this is a really important point for those of you in general medicine, of course, and those of you who work in the emergency department, and we see this time and time again, okay? So the tonic-clonic convulsion, which is an obviously horrendous event to happen and scares people and scares families and is an obvious clinical event, is the straw that breaks the camel's back that brings people to medical attention. But frequently, individuals who present with their first seizure, first convulsion, have had previous minor, if I use that term, seizures which have been unrecognized by either the patient and the family or undiagnosed by the patient's doctor, the GP, or perhaps a specialist. We had an excellent lecture from Dr. Burns on the appropriate investigations of celiac disease, but I've seen quite a few patients over the years who have undiagnosed temporal lobe epilepsy simple partial seizures, who experience feelings of nausea and rising epigastric sensation, which to me is bread and butter. And when I hear the story, I generally know what's going on. But these patients frequently are misdiagnosed or undiagnosed. They have upper GI endoscopy. They're told their endoscopy is normal, and they're told off they go. And they experience frequent clusters of these simple partial seizures, and nobody knows what's going on until they have a tonic-clonic convulsion. And this is engaging the community worldwide now. The point is that there are a lot of people out there who have active epilepsy, and they don't know they have epilepsy, and their doctors don't know they have epilepsy. So this is something to be aware of. Now, without putting words in the patient mouth in the emergency department when they present with their first convulsion, you have to ask about other symptoms like some GI, rising epigastric sensation, other symptoms, smells, taste. They can be more difficult. Obviously, the phenomenon of déjà vu is also difficult because that can merge in with normal experience. Also, in a form of epilepsy which accounts for about 8 to 10% of epilepsy in adolescents and young adults, called juvenile myoclonic epilepsy. Again, the convulsion is often the event that brings the patient to medical attention, and they've been experiencing myoclonic jerks, usually out of wakefulness, usually in the morning time, which are epileptic myoclonic jerks. These are jerks that occur out of wakefulness, worse often by tiredness. They're not the hypnic myoclonic jerks that we will sometimes experience as a part of normal experience, particularly when we're very tired and we're falling asleep, and we will experience a hypnic jerk. That is, many of you will have experienced that. This is normal. This is a different issue. So the point is, inquire about other seizure types when somebody presents with their presumed first seizure. Okay, and this is a really basic slide, but I have to get it out of my system today. It is amazing the term absence is still abused, even by consultant neurologists. So an absence and a complex partial seizures are not the same. They're very different. An absence seizure occurs within the setting of idiopathic generalized epilepsy. A complex partial seizure occurs in the setting of a focal epilepsy, and that's 85% of the time temporal lobe epilepsy. Again, I'm not going to read through this, but we need to get our language right, and somebody who stares off and has lip smacking and automatism plucking at their clothes, and it lasts 30, 60, 90 seconds, and they're tired afterwards. That's not an absence, that's a complex partial seizure. Okay, so I don't think that we have been thinking enough about fundamental cause of disease in medicine, and we now have the wherewithal to begin to do this. And this is particularly so in the setting of epilepsy. Somebody has temporal lobe epilepsy, somebody has idiopathic generalized epilepsy, somebody has Lennox-Gastaut syndrome. This is a severe type of epilepsy in childhood where children have multiple seizure types. They wear a helmet, they have drop attacks, and we just call it by a syndromic diagnosis. But we need, the International League Against Epilepsy classification has basically done, or thinking about this, a disservice, and I think we need to think more about cause. And similarly, in other related fields such as intellectual disability and autism, I don't know what autism is. There are many people out there that come in, this person has a learning disability or intellectual disability. We now need, and I will talk a little bit about genomics in a second, we need to think about the underlying pathophysiology of these brain disorders, because these are just ragbag diagnoses. The other thing is that we are now understanding from advances in genomics that a lot of these patients with epilepsy or intellectual disability or autism are harboring mutations in genes that affect a lot of different pathways, that the mutations themselves are individually rare, but collectively, in terms of phenotypically causing severe epilepsy with intellectual disability, causing autism, are collectively common. So this individually rare but collectively common paradigm is important to think about in these conditions. Again, I know I'm sort of skipping around, but I'm trying to give what I think are important perils, P-E-A-R-L-S, and avoiding perils. At the end of the, when we report on a routine EEG, and at the end of the report, we generally say a normal routine EEG does not rule out the diagnosis of epilepsy. And this is absolutely 100% true. In fact, you could say multiple normal routine EEGs does not rule out the diagnosis of epilepsy. On the other side of the equation, an EEG can be abnormal, and it might be reported as being abnormal, and then the non-reading, or the reading non, or the individual or the physician who's caring for the patient, reading the investigation might interpret some sort of abnormality on the EEG as being indicative, such as focal slowing, or other abnormalities on the EEG, and that there would be then interpreted as evidence of epilepsy, and this isn't always not the case. So a test could be normal and the patient has a disease, a test can be abnormal and the patient doesn't have the disease. Similarly, there may be incidental omas on imaging. I recently seen a woman who's extremely anxious because she told she had a temporal lobe arachnoid cyst. She had some headache, and then she started developing other spells, and these were clearly not epileptic. She was just in a panic that she had a cyst on the brain, and this of course is benign, and if we bring in 100 people over here from Grafton Street and image them, we will see incidental omas on imaging. So it always, of course, has to be interpreted in a clinical context. And when we're in difficulty, we have now the luxury of having 4-bedded video EEG unit in Beaumont. My colleague Danny Costello in CUH has a 2-bedded video EEG unit, and you have no idea as an epileptologist the wealth and the value of the information we get from video EEG, inpatient video EEG monitoring, in terms of differential diagnosis of people who are having spells, evaluation of complex patients, and of course for pre-surgical evaluation. But inpatient video EEG, you cannot, in 2016, practice complex epilepsy without access to inpatient video EEG monitoring. I've said some of this already, but for those of you who are ordering a routine EEG, and I know it can be frustrating because in many hospitals around the country you can't even get a routine EEG within that hospital, but an EEG, a routine EEG is only a 30 to 40 minute snapshot. It's state dependent. When we get drowsy or fall asleep, we go into physiological coma, so we see slowing. So it can't be reported as showing slowing and then being interpreted as being abnormal. If the patient is asleep, then they're going to be slow. One has to be wary of artifacts and benign variants. a routine EEG capturing wakefulness only is almost useless. Okay, so our technicians, our EEG scientists really put in a lot of work into capturing sleep. Sometimes we would specifically request a sleep-deprived EEG, which increases the yield, because a lot of abnormalities, epileptiform abnormalities, focal sharp waves, focal spikes, only are apparent when somebody falls asleep into stage 2 sleep. So a routine waking EEG essentially is nearly useless. And also, of course, EEG is important in general ICU for the evaluation of encephalopathy in sick hospitalized patients. This is a normal, eyes closed, normal, awake EEG. The portion on the left here, I think this is after packing up, so I don't have a pointer. Yeah, no, it's after. The ghost in the machine. I'm not sure. Oh, yeah. So the patient here has their eyes open. I won't go into, this is called a montage. Basically, each squiggly line represents the voltage difference between 2 fixed points on the scalp. By convention, if input 1 is negative with respect to input 2, the deflection of the pen is up. So basically, the patient closes their eyes, and this is a biological artifact because the cornea is positive and the retina is negative, and by Bell's phenomena, when somebody closes their eyes, the EEG is affected by this. But this here, this spindle-shaped activity at the back of the brain, take my word for it, this is occipital, is the normal awake alpha rhythm. So this is a 10-second page of eyes open and then eyes closed, normal background rhythm. Okay, this is another thing that causes huge problems in clinical practice. If I had €1 for every patient with difficult epilepsy that I've been referred over the years that said the MRI is normal, I would be quite wealthy now. Of course, MRI is the imaging modality of choice, except maybe in occasional patients, for example, maybe in elderly patients who have cerebrovascular disease or have an obvious hemorrhage. They argue that you may or may not want to get an MRI. For somebody who's from the African subcontinent and who presents with their first seizure, then it is possible to probable that their epilepsy might be related to neurocystic sarcosis, so you'll be better off seeing this calcification on CT rather than MRI. But generally, of course, MRI is the imaging modality of choice. But I'm talking about an MRI that people think about and the appropriate person evaluates. I'm not talking about an MRI that's done in the back of a lorry somewhere in County Longford, with all due respect to people in County Longford. It has to be ordered, it has to be prototyped, and it has to be read by somebody who knows what they're looking at. So many subtle lesions on MRI are missed, including potentially surgically remedial lesions that will control the person's epilepsy. These would include mesial temporal sclerosis or hippocampal sclerosis, and also subtle cortical dysplasia. And of course, this whole field is moving because we're now using 3 Tesla MRI, and some units are even not in Ireland yet, but are using 7 Tesla MRI. So and this is helping us see more subtle lesions, particularly subtle cortical dysplasia that's been there since birth but may just manifest in childhood or adulthood as presenting with epilepsy. Okay, so these are some examples of subtle lesions that have gone through the epilepsy program with refractory epilepsy and who've had an operation and are now seizure-free. Obviously, the overall success of epilepsy surgery, particularly in somebody with temporal lobe epilepsy or with a lesion, is about 70% seizure freedom. Not everybody becomes seizure-free. So this is a small polycytic astrocytoma here in the right occipital region. This is high signal in the right hippocampus associated with hippocampal sclerosis. And this is a benign but epileptogenic tumor with a cystic component with dysplasia, a dysembryoblastic neuroepithelial tumor in the left temporal lobe. All these were removed, and obviously they went through the surgical program, and these patients are seizure-free. Obviously, some are more obvious than others, but you could imagine this could be missed or just be misinterpreted as a little bit of superficial white matter disease. Okay, this is again not a lecture on anti-epileptic drugs, you'll be glad to hear, but there are many, many anti-epileptic drugs. How do you keep up? I'm not going to say, you know, Dr. Delanty, which drug do you use first in epilepsy? I mean, that's a very complex question to answer, but there are obviously a number of medications that are used more first line now, and then the other medications are used under more specialist advice. Newer medications, if they're good, like rising cream, they're going to rise up the pecking order and be used more first line, second line. There are even drugs that are not on this list, two new drugs, a drug called perampanel, which is an AMPA receptor antagonist, and a new levetiracetam derivative, brivaracetam, which is currently undergoing the bartering process with the HSE at the moment for funding. So this is obviously difficult. Just traditionally, years ago, in the years of Dr. Callahan in CUH, if somebody had partial epilepsy, and that was usually temporal lobe epilepsy, the drug of choice was carbamazepine, Tegretol. If somebody had generalized epilepsy, like idiopathic generalized epilepsy, absence, JME, the drug of choice was sodium valproate. It's more complex than that now. We would still use carbamazepine, but we use other carbamazepine derivatives, particularly eslicarbazepine. We will use levetiracetam. For those of you who think in trade names, Keppra, lamotrigine, Lamictal, and the latter two drugs can also be used quite successfully for some patients in the generalized epilepsies. But it is a complex area in terms of what drugs to pick, particularly once people start failing the first and second drug. Again, this is really basic. It's so basic that people forget about it. Patients with epilepsy come in, they're anxious. There's obviously a huge life-changing event if they're diagnosed with epilepsy, or they may have refractory epilepsy, they may have cognitive issues, they may have memory issues. And if you're starting a drug, the mantra that is start low and go slow, etc., but we're frequently building up medication slowly, taking away medication slowly. Some medications you have to build up slowly because of tolerability or safety issues. For example, drug X here could be lamotrigine, and you have to build it up over 7 or 8 weeks because that reduces the incidence of hypersensitivity. But these patients, we have specific drug calendars on the ward and in clinic where this is written out, spelt out, dated out, so that the patient and the family knows exactly when to change the medication. And if some drug has been withdrawn, we do a similar thing for the withdrawal process. Don't expect take this and increase it by 25 milligrams every week. It doesn't work like that. So you've got to spell it out for these patients of what you want to do for their drugs. And I have seen patients come in on lamotrigine 25 BID when they were started in an emergency department somewhere, and nobody bothered to explain to the patient. I mean, 25 BID is just literally the start of the schedule, and patients need to get up to 100 BID. I say I'm already talking too much. Those of us from Cork, and I'm not an Irish Times debating champion like our next speaker, we tend to speak very quickly, and we still can't even get in what we want to say. So just forget about the old definition of status epilepticus. If somebody is seizing, you've got to stop the seizure. Forget about rectal diazepam. We are now using buccal midazolam. Forget about licensing. These are 2 slides from one of our epilepsy nurse specialists, Yvonne Owen. So we now use buccal midazolam. It's in 2 present formulations. Buccalam, which is 10 milligrams in 2 ml, pre-syringe, and midazolam or epistatus, another form of midazolam, which is 10 milligrams in 1 ml. But every patient who has difficult epilepsy, every patient who presents with a convulsion needs to be prescribed rescue medication. Nearly there. The tyranny of drug levels, I'm not going to read through it, because how much time do I have? 2 minutes? Oh my God. It is amazing. People do not look at patients, they look at a piece of paper on their desk. Patient has a phenotone of 21, it's toxic, their lab says they're toxic, the patient's walking around perfectly seizure-free, somebody reduces their phenotone by 100 milligrams and they have a seizure. It's the intelligent use of, like everything in medicine, of the investigations in the clinical context. Similarly, for other blood tests, if somebody has a sodium of 128 on carbamazepine and they're well, forget about it. If somebody has a low white cell count on carbamazepine, 3.5, they're well, they're not getting infections, forget about it. I had a patient came in to me last year, the GP did an FBC, the white cell count was something like 1.8. Patient was perfectly well and had been on the same dose for years. The patient came in wearing a mask because the GP advised him to wear a mask in case they get an infection. Beware non-epileptic seizures. Do not use the PS or pseudo-seizure word. Patients and families don't like this. Cardiologists don't talk about pseudo-chest pain. They talk about non-cardiac chest pain. These are common in neurological practice. And just a point to take away, if you think somebody has a non-epileptic seizure or psychogenic seizure and it looks really, really, really strange, it's likely not to be a non-epileptic seizure. It's likely to be a frontal lobe seizure. So there is a big issue with regard to the differential diagnosis between frontal lobe epilepsy and non-epileptic seizures. What about syncope? I've seen a lot of convulsive syncope. Convulsive syncope occurs in about 8% of faints. It's underappreciated, underdiagnosed, and of course, like iron deficiency anemia, syncope is not a top-order diagnosis. There's a big difference generally between a healthy 20-year-old having vasovagal syncope and a 68-year-old with vascular risk factors who has syncope. They're completely different issues. Okay, nearly finished. Can I I need water. Regina McFadden is in the audience. Regina's done great work with Professor Des O'Neill over the last few years in the traffic medicine department. Unfortunately, she's leaving us, but driving is a huge issue. The worst call we can get is that there's a truck driver down in the emergency department who's had his first seizure, because you know you're going to have to go down and take this person's livelihood. But even for Group 1 licenses, cars, it's a huge issue. I'm not really going to get into it unless there's, because people are getting edgy, unless there's particular questions. But somebody with epilepsy, on or off medications, can drive if they're free of functionally disabling seizures. We can argue about what functionally disabling seizures are for 1 year or longer. There's other issues like nocturnal seizures and simple partial seizures, but 1 year free of functionally disabling seizures, one can drive a Group 1 vehicle, of course not a Group 2 vehicle. I said I wasn't going to talk about drugs. Just if you're prescribing Epilim or sodium Valproate, I think now Valproate should be prescribed only under specialist supervision, and certainly, with all due respect, not supervised, not prescribed by general practitioners. Sodium Valproate, this is not new. Well, some of it is new. 10% major malformation rate, 30% cognitive hit, even if the baby is normal when you follow them through school compared to their peers whose mother has been on other anti-epileptic drugs, an IQ point down of 9 or 10, and 4 to 5 times risk of autistic spectrum disorder. Valproate is a nasty drug, and do not put it on do not start the drug on women of childbearing potential. Some women will need it, but that's a specialist issue. In the interest of time, I'm not going to discuss this. I thought I had only 30 slides. I don't know I'm out of time. Okay, we're in a new era of medicine. Forget about single gene tests. We're now doing gene panel testing, exome sequencing. Obviously, we got to get the system and our administrators and our politicians to understand the importance of the new genetics. And we also need to understand that genetic disease now is not necessarily hereditary disease, because a lot of disease, such as learning disability and such as epilepsy, severe epilepsy of childhood particularly, is caused by de novo mutations, usually in one or other of the parents, more commonly in the father, because fathers continue to make sperm throughout their life, whereas women, eggs are made earlier on. We need to be an advocate for better clinical genetics and genomic resources in Ireland. We are so far behind in genetics and genomics in Ireland. We've no genetic counsellors, very few genetic counsellors, very few clinical geneticists. And this is a huge issue, I think, in medicine right now, and will be for the next 10 or 20 years. And the other thing is that genomics is going to lead to what's now called precision therapy. We won't necessarily be using Tegretol or Keppra to treat somebody's bad epilepsy. We will be using a medication, either a novel medication or a repurposed medication, to treat a specific disease associated with a specific mutation. Okay, I've said about epilepsy surgery. And final slide, there must be a picture of Robert Bentley Todd in this building somewhere. He liked to prescribe large doses of alcohol to his patients, including to himself, and that's what it was his demise. But the reason why I put this up about Todd's paralysis, I see a number of my geriatrician colleagues, including Dr. Martin, in the audience. The point is, modern textbooks will give you the impression that Todd's paralysis will only last minutes or hours. If there's underlying structural brain abnormality, or in the elderly, a Todd's paralysis or a Todd's aphasia can last several days. So bear this in mind. And okay, I stop. Anybody who hadn't been to the Skelligs, you should go before they close it up. Thanks very much.